I'd like to talk about a specialized part of the ischemia trial, and that is the implication for the use of non-invasive techniques, including coronary CTA and myocardial perfusion imaging. As my disclosures, I was the director of the nuclear cardiology core laboratory under the direction of Leslie Shaw. What I'm going to talk about will be my personal perspective of a multimodality imaging cardiologist, 5 decades of experience in nuclear cardiology, 4 in cardiac MRI, and over 2 decades in cardiac CT. First, as a background, let's just go over the trial results. As Leslie has indicated, no reduction in composite or heart events, sustained improvement in quality of life and angina, no heterogeneity of treatment effects, regardless of the magnitude of ischemia and the magnitude of coronary artery disease, including the number of vessels involved and the presence of proximal LAD stenosis, which was present in nearly 50% of the patients. The strength of the trial larger than all prior randomized trials combined. They were randomized on the basis of ischemia, and there was core lab interpretation of ischemia in most patients. The limitation, selection of the least sick patients, where the physicians thought there was clinical equipoise, really affected the trial. 29%, as Leslie mentioned, had no angina in the last month, and nearly a half had either no angina or class 1 angina. There was treatment-guided optimal medical therapy, as Leslie mentioned, with questionable generalizability. 14% were not core lab eligible, and left main stenosis was excluded, and that was in 5.8% of the patients. So what are the implications for coronary CTA? And first, I believe that ischemia will accelerate current trends in the use of CTA and myocardial perfusion imaging. Here we see a patient whose coronary CTA showed a very prominent severe stenosis of the left main, confirmed at the time of catheterization. What we know is that left main was excluded not only in the ischemia trial, but also in the Courage, VERY2D, and FAME trials. 6% of the enrolled population were excluded in ischemia because of left main stenosis. And we still will have the need in applying the results to rule out left main stenosis. Coronary CTA is the most accurate diagnostic test for the detection of coronary disease greater than 50%. This is a large meta-analysis demonstrating that. And for years, we've known that the prognostic value of coronary CTA is extremely high based on the extent and severity of abnormality. These are factors that are increasing beyond. These are the factors increasing the use of CT, including now the ESC guidelines for the management of chronic coronary syndromes, where non-invasive testing or coronary CTA has a class 1 indication for diagnosis and should be used and is used for risk stratification. Now, this use of CTA was guided by evidence showing that it was the most accurate for obstructive coronary artery disease. But we know that there are multiple features beyond prognosis, beyond stenosis, that contribute to rupture-prone plaque, as nicely illustrated over time by Dr. Narula. Many of these features are accessible by coronary CTA. Low attenuation plaque representing the necrotic core, positive remodeling, the very large size of a given plaque, spotty calcification, and something by CT we call the napkin ring sign. There are also exploratory studies demonstrating prognostic possibilities by looking at a marker of inflammation with CT. Now, this slide from Dr. Narula's group just illustrates the visibility of plaque that we don't see at the time of cath on the coronary CTA, with two of the positive high-risk features being illustrated: positive remodeling, outward bulging of the artery, and low-density plaque, which represents the necrotic core. These are the high-risk features, and we know from multiple studies that these features add the stenosis for prognosis, beginning with Dr. Narula's lab in 2015. Now, beyond the visible assessment, visual assessment of plaque burden and plaque characteristics, automated assessments of plaque are soon to become available, including the percent stenosis measured by software, non-calcified plaque, and importantly, this low-density non-calcified plaque, as well as other features that put together by machine learning, which is now evolving in the field, provide a strong assessment of the influence of plaque. And quantitative plaque features have already been shown to predict FFR ischemia, to predict mortality, and to predict myocardial infarction. Beyond plaque, we now have the ability with CT to assess functional ischemia non-invasively. And here we see from the largest trial, or the most recent trial, the NXT trial, that the principal effect of this FFR CT over cath stenosis or CT stenosis was in improving the specificity of the CT examination. It's highly sensitive, but its specificity is lower. So the implications for coronary CTA will positively affect these trends toward growth. There'll be still a need to rule out left main disease or clinically important proximal LAD disease. It will add to these trends that are accelerated by guidelines, by functional assessments, by plaque assessments, and by the future of machine learning. There will be a slowing of this affected growth, though, because of decades of experience in ischemia-guided management, the lack of availability of high-quality CTA examinations around the world, including equipment and technologists and interpreters' expertise that is highly relevant to the coronary CTA, and the difficulty interpreting scans in patients with high calcium scores, particularly even by experienced observers. Now, the implications of the trial for myocardial perfusion imaging are clear, are several. First, we should recognize that the ischemia trial was not a trial of effectiveness of ischemia testing. It was a trial of a strategy of high-risk ischemia patients. In the guidelines, as coronary CTA has been given a class 1 indication, functional testing also remains class 1 indication in the European guidelines. As Leslie has illustrated, even recent data has demonstrated to us that SPECT ischemia predicts mortality benefit with revascularization. This work from our laboratory with an automated assessment of the perfusion defect size shows that either MACE events or all-cause mortality are predict the benefit for these has been shown with a percent of abnormality of the myocardial perfusion scan. Here with contemporaneous information, not 30 years old or 20 years old, that is contemporaneous with the ischemia trial. Beyond this, we have data from Krishna Patel and Tim Bateman that has demonstrated that we also look at flow reserve that can be measured with PET or with CMR. We see this illustration of benefit from revascularization. And then finally, the coronary, the myocardial perfusion SPECT can now be routinely combined with myocardial perfusion imaging. So in the setting of a mild perfusion defect, if we add the extent of calcium now available with SPECT CT and PET CT systems, then we are able to better judge the implications for prognosis and potentially the need for revascularization with the addition of the coronary calcium. And I'd point out that no randomized trial has compared the combination of myocardial perfusion imaging with coronary calcium to the coronary CTA alone. Finally, going back to what Leslie has indicated as highly important, the patient's questions are not only, am I going to live, but importantly, what's causing my chest pain and can you relieve it? And here it's myocardial perfusion that determines the presence of ischemia in patients with coronary artery disease or patients with non-obstructive coronary disease who have ischemia. Dynamic perfusion methods allow us to assess diffuse atherosclerosis, myocardial dysfunction, or collaterals that are not assessed by either FFR or FFRCT. The trial factors that will reduce the negative impact on the use of myocardial perfusion imaging include generally, as we know, the less than expected impact of randomized trials. The trial limitations, with an important one being the selection bias of the patients who have clinical equipoise, and the fact that it was not a trial of ischemia testing, and there was minimal use of PET or CMR. This factors that are other factors reducing the negative impact include the specific strengths of myocardial perfusion imaging, continued recommendations and guidelines, current observational evidence that's recent of revascularization benefit on the basis of ischemia, wide availability, the ability to determine the cause of symptoms, the use of the techniques in patients who have contraindications or challenges for coronary CTA, and the use of combined anatomy and function that we can get by SPECT CT or PET CT employing coronary artery calcium scanning. So in conclusion, I think the impact of this trial on clinical practice will be that we'll have more medical management first, even in patients with high-risk ischemia or obstructive disease. We will have an increase in the use of coronary CTA fostered by the findings with the continued need to rule out left main disease or proximal LAD stenosis, and it will add to the other factors increasing the use of CTA. The use of myocardial perfusion imaging will be negatively impacted, but mitigated by the lack of infrastructure and expertise, by the CTA limitations and coronary contraindications, and the need to assess whether symptoms are from ischemia. So thank you very much for the opportunity to present.